But it was clear that that was going to be the only evidence that we were going to have. The National Institutes of Health had a hydroxychloroquine azithromycin trial. They started in the spring. They had shut it down within a few months. They only collected 20 patients. They had scheduled to collect thousands of patients. All these other hydroxychloroquine ivermectin studies were, in a sense, were kind of administratively killed over the year. They never were brought to completion. We needed trials of 20,000, 40,000. I'm a cardiologist. This is what we used to. Didn't see it. We didn't see it. In fact, we were so interested in the early use of hydroxychloroquine that Joe Ladapo from UCLA as the first author gathered together all the trials stopped early. All of them that declared no benefit to hydroxychloroquine. But hydroxychloroquine was always ahead a little bit in each one of the studies. When you compiled them all together, there actually was a statistically significant benefit, about 25% reduction in the outcome.
So the Senate hearing happens. You get the dissenting voice. It seems like everything is pushing toward a vaccine agenda, and anything that is not aligned with that agenda is misinformation. I mean, is that pretty much the feeling you were getting?
No, but I was wary of the idea that, despite our best efforts, that we would be somehow wrongly accused of misinformation. And boy, Dr. Harvey Risch, he was pinpoint on the citations. We had a first author listing. I made the case. There's a picture of me holding up my protocol. My hair is a mess because I'm trying to recover from COVID-19. I'm trying to wear an N95 mask and do all this. And I just said, this can't be controversial. We're talking about prednisone. I mean, we use that for asthma. We're talking about Lovenox. We use that for blood clotting. And aspirin. How can that be a lightning rod here? I was trying to diffuse all this incredible focus on hydroxychloroquine or ivermectin. That we absolutely positively know not a single drug is going to cure this problem. We don't have single drugs for fatal infectious diseases. Never. And a mistake would be to say, well, it's all about this drug. And if you can't do this drug, you shouldn't do anything at all. And it almost seemed like that's what the argument was. Well, what had come out in after that is we went about our academic lives. But the minority witness in, I think, what was really a shot across the bow and really a low blow in terms of unprofessionalism, is he took the liberty of publishing an op-ed in the Wall Street Journal where he called Senator Johnson, myself, George Freed, and Harvey Risch. He called us snake oil salesmen.
Whoa.
Snake oil salesmen. And can you imagine? That's from a junior physician today.
I was going to say,
he's junior.
He doesn't have
he's junior.
He doesn't be able to make that assertion.
He doesn't have 650 publications. He doesn't have a major contribution to his name.
Yeah.
And wow, that got into the Wall Street Journal. So the junior doctor is calling the senior doctors snake oil salesmen. And Senator Johnson was incensed. He tried to publish a reply. That never went anywhere. The Senate hearings came out on C-SPAN. But they were systematically blocked. You turn on any of the major media, it's like as if nothing happened.
So let's fast forward to where we are today. There are videos being taken down off of media platforms like YouTube that aren't like somebody in their basement making a video and spouting stuff. We're talking about C-SPAN, at Congress in Washington D.C. recording what's going on there, and that is taken down, saying no, you can't see that. You can't even see what's going on at the Capitol. I mean, so are you seeing now that this anything that's not aligned with the vaccine is the only answer agenda is just being taken away, and there's a tax on the people who have a different point of view?
Yeah, that's an important point. November 19th may actually be a very important historical point, because the whole purpose of Senate hearings are to get information to Americans. It's for America.
Right.
It's not, these weren't closed hearings. There was nothing confidential here. This was actually to America, and especially to not have it even summarized in the major media, and then have a really derogatory opinion editorial from the minority witness, which is really out of, he's a witness. He shouldn't be turning around and then trying to report to America through the Wall Street Journal. That was just dastardly, if you will. It's very unprofessional. And of course, Senator Johnson said, well, what do you think about this? They're calling us snake oil salesmen. And I tried to turn it into a positive. I said, every time there's an innovation, it's met with enormous skepticism. And maybe this snake oil salesman is really just an expression of skepticism, that you really can't do this. I had already received these letters to the editor. I'd already seen the skepticism. Like, you can't treat COVID-19. You can't do it. It's untreatable. It's unbeatable. You can't. You have to wait for the vaccine. Well, there was a second Senate hearing on December 8th, and I helped Senator Johnson set up the lineup. Pierre Corey, it had Dr. Jean-Jacques Rochter, who had published the largest and highest quality U.S. study with ivermectin. We had Dr. Jane Orient, Dr. Raymond Ascui, and several others, a bigger panel. And there they came in strong on ivermectin, and Pierre Corey made an impression. He showed up in the Senate floor wearing his white lab coat. And he told America that people were being slaughtered by the virus. He, as an inpatient doctor, which I'm not, he was seeing this happen, and he, as well as Dr. Rocher and others, had concluded that we had to treat this before the hospitalization. They, as ICU doctors, were telling America it's too late to start treatment in the ICU. And Dr. Rusher had already shown, he published his ICON study in Chest, one of the best journals, that ivermectin clearly had an impact. Now, would we have wanted to have $500 million, large-scale, randomized, pharmaceutical-supported Operation Warp Speed trials? We would have loved that, but it would have cost a ton of money and would have taken a ton of time. And we didn't have it. Americans were dying. So we really kicked things into action. There was a whole confluence of things. AAPS guide was being broadly used. Telemedicine services sprang up. National ones sprang up. Regional ones sprang up. AAPS kept a list of treating doctors. There was even a global list of treating doctors. So Americans started to realize, listen, if my doctor turns me down on treatment, I can find some treatment. Most of these doctors were just calling in for monoclonal antibodies. We had a large number of these monoclonal antibodies. They were EUA approved. Great opportunity to start treatment with those. I love treating with EUA. I have somebody today developing COVID-19, high risk in my practice, getting the EUA antibody. So a great way to receive FDA, EUA, Operation Warp Speed, high-tech, big pharma products. I mean, you can't beat it, right? I mean, that's American ingenuity, and we wanted to highlight that for America, and then follow with these evidence-based sequence drugs. So we had a big curve in December. Now, looking back on it, maybe some of it was contributed by influenza. We don't know, but we know early treatment really kicked in, and that we saw a simultaneous reduction in new cases, hospitalizations, and deaths. And the only thing that can really hit that, in my view as an epidemiologist, is early treatment. Because early treatment cuts down a viral replication phase from 14 days to about 4 days. So the infectivity per person is dramatically reduced. It's the only way to do that. Letting somebody sit at home and bake with COVID-19, they're going to spread it. Yeah. People are going to come over. There's going to be, this is what's going to happen. So we think early treatment had this big crushing effect on the curve. And by February 1, we had fewer than 30 million Americans who had received any form of vaccination. We knew that the vaccine trials coming out, they looked like about 90% vaccine efficacy for all the trials, recruited pretty low-risk populations that didn't come in contact with COVID. So the rates of COVID occurrence, binary occurrence, were less than 1%. In the treatment group and in the placebo groups.
So can we pause that for a second, because this is a part of what is being touted as data right now, efficacy, 90-95% efficacy, but what do they mean by efficacy? And does it prevent you from getting COVID? Does it prevent you from spreading COVID? And I speaking of the Lancet, I reviewed an article in the Lancet that really got my attention, because they said, let's talk about the elephant in the room. In these trials, they're talking about relative risk reduction, not absolute risk reduction. So can you speak to your views around that?
Sure. So relative risk reduction, or a derivative of vaccine efficacy, or VE, is the idea that in theory what it means is, in theory, if you came in contact with COVID, you would have 90% protection from getting COVID. That would be the best possible interpretation. The reality is, if in placebo, less than 1% of people get COVID, that means that there wasn't much of a challenge. Right. That meant that if there was 18,000 in a placebo group, they never, it's either placebo is really good, which it isn't, they just didn't get the contact. Okay, so when we're below 1% for both groups, that means the absolute risk reduction is going to be less than 1%. And provided that exposure rate to COVID is relatively constant, and provided over time things don't change, that the interpretation of that is the vaccine program could never impact an epidemic curve. It's impossible.
Because what that means to me as the consumer now is that my absolute risk, meaning not what happened in the trial, but what's going to happen to people out here in the real world if you extrapolate, is that it doesn't reduce my risk by maybe 1%, as compared to saying, oh, now I'm 95%.
It's true. Well, as you walk around, don't forget the big thing is exposure. The other thing that can happen is if it's just a 2-month trial, and if all vaccines rely on principles of immunity and the immunity wanes, as exposures pick up and immunity wanes, that 90% can only go down. Right. And we started to see that early on. There were papers, there's one out of Denmark, I recall, that it was done in nursing homes. And the nursing home residents, the calculated vaccine efficacy was about 70%, but of the nursing home workers was 90%. But we started to see, wait a minute, now the groups that we really want to protect, maybe the protection isn't as high as 90%. But having said that, they look good. It looked like the reactions in the arms and the lymph nodes and rates of Bell's palsy, what have you, were real. But coming out of the trials, I would interpret that as to be acceptable. I didn't voice. We were asked at the end of our November 19th hearings, did anybody on the majority witness side have any questions or concerns about the vaccine program? We remained silent. At that point in time, it was a press release. I had nothing to say. I saw the press release data, but being I guess, a wizened academic physician, we never comment off press releases. We want to see the data.
Yeah.
When we saw the briefing booklets, and the first one we saw was Pfizer, we saw something interesting, and that is we saw actually a little flurry of suspected COVID and confirmed COVID after the first injection on the vaccine side of things, which was interesting. Now, it was curious that maybe just people got confused regarding the reaction that they were having from the vaccine, whether or not they came into contact. And then there were non-randomized reports that came from France and Israel showing the same thing. And so I think there's now a general acceptance that there's actually a little bit of a susceptibility to COVID if exposed after the first shot.
I was just actually reading something about that, exactly what you're saying, and so that after the first shot you're actually more vulnerable rather than more protected. Yet there's no protocol saying between your first and second shot you should isolate, you should quarantine, you should do anything to protect yourself. And one of the things I'm really glad about is the details of the history of just your personal history and kind of the world you come from and how serious you take academic medicine and how serious you take epidemiology. I think that's important. And then seeing how this whole story unfolded when we were kind of like disoriented, like nobody knows what's going on. We're all concerned. We think there might be this really bad thing that's going to happen, and now we are where we are today. Okay, so we're at a point now where we have data. We can look at states like New York and California, which behave very differently than say Florida and Texas, where you're from. We have the vaccine now. We got hundreds of millions of people who are vaccinated. And now they've been vaccinated for some period of time, and we're seeing variants come, et cetera. Now I think there's perspective that didn't exist when you were testifying in front of the Senate, last November.
Yeah.
So if we kind of get into, for lack of a better term, a lightning round of topics here, with now you have the perspective to be able to look retrospectively and say, okay, here's what's going on. First, let's start in the non-clinical sense and saying, you've told your background, your story, but yet you're really being vilified, in pretty malicious ways right now.
Well, things were picking up through the year going into the Senate testimony where, there was talk around the hospital that I was, in a sense, a maverick. I was treating 5 patients, and I took on that responsibility. I carefully documented things. I was, in a sense, the medical monitor for the Baylor hydroxychloroquine trial. I was asked by officials to always say that my opinions were my own and not necessarily those of the institution. And I can tell you my entire career that is the case. My opinions are always my own. I never put out a position on behalf of any organization or employer, ever. And as an academic doctor, I have a natural set of ties, and it's impossible to sever those ties that exist. So there's profiles. I think when things came to a head, there was a search. There was 800,000 profiles on me on the internet, professional profiles, over 16 million hits. So these connections are impossible to break. Having said that, my opinions, the words that come out of my mouth are always my own. So I honored that request of saying, and specifically at the Senate, I said these are my opinions of my own and not necessarily my institution. And I've always sent out to various producers, some sets of this is my current sets of titles. But the problem is the titles and the positions eroded. So by the end of January, my contract was not renewed. I was previously employed by Health Texas Provider Network, which is a doctor group under the umbrella of the Baylor Scott and White Health System. So it's complicated. So doctors can't directly be employed by hospitals, but we're employed in physician groups that can be in a parent operating group. And I still have independently, I have, and still do today, staff privileges to take care of patients at Baylor Heart and Vascular Hospital and Baylor University Medical Center. So those relationships are there. And so I literally had to scramble, and doctors in many sense are they're like professional football players, professional athletes. I went on waivers and I got picked up by a private practice and was able to move my patients into a private practice on the same campus in an office that is on the Baylor University Medical Center with my full privileges. I changed my malpractice. So all my medical staff privileges, and by association, Baylor kept me up on their website as a cardiologist and all that. I had a separation agreement where we settled on terms because of the unusual nature of this. It's not like this wasn't a usual employment transition. And the stated reason why they didn't renew my contract, which was like an evergreen type of renewal, was no reason. Wow. And so I had developed the feeling that this was a retaliation for my efforts in helping patients and trying to treat patients with COVID-19, and how I had taken on a role with the U.S. Senate, the media. I had promulgated some important points. One in the Senate was the 4 pillars of pandemic response, which really was published in December of 2020, but emphasized that our public health response should always have something about trying to reduce the spread of the virus. A big focus on early treatment, because the sick people, those are the people that are our biggest concern. To do the best we can in the hospitals, pillar number 3, and then vaccination or herd immunity, but a balanced approach. And I had started through a series of publications in the Hill, a journal, Washington Journal, a window to America, basically telling them what I thought people wanted to know my opinion. And lots of people did. And so it wasn't just the White House, but the Senate, many others. And so I published one. I published in the summer. I said the great gamble of the COVID-19 vaccine development program. It appeared to me by the summer of 2020, we were putting all our eggs in one basket for a vaccine. We didn't see the investment on early treatments at all. We didn't see things moving along. There was no big American push to get Americans into research. There was no 800 hotlines, no public service announcements. And as it came forward, even when the monoclonal antibodies came out, they weren't widely advertised or made available. It just looked like it was going to be all about the vaccine.
Right.
So I made a professional transition, and through the course of December, January, and February, I didn't encourage or discourage the vaccine because it was a voluntary program, and people could sign up for it if they wanted to or not. And we didn't know much about it, honestly. We didn't know much about the mechanism of action. It's not like we had dozens and dozens of messenger RNA or adenoviral DNA vaccines. We didn't have any, and people started volunteering for the vaccine. And about 70% of my practice took the vaccine, patients in my practice. Various doctors and nurses did, but not all. And it was a voluntary program. I don't think anybody had too much of a problem with it. By looking back, we actually developed a mortality signal on January 22nd.
What's that mean?
That means that there were excess numbers of people dying after the vaccine that were being reported to the vaccine adverse event reporting system, exceeding the level of comfort. So if the universe of total number of shots that Americans take per year is roughly 278 million across 70 or so vaccines, that in the database, year by year by year, if you actually looked all vaccines, if you searched it, you see about 150 a year, sometimes 120, our average is about 150. We had already hit 186 with the COVID-19 vaccines alone by January 22nd. That was only with 22 million Americans vaccinated.
And do you feel that was only 22 million that were vaccinated at that point?
Yeah, I'm sorry, maybe 27 million.
Okay, and simultaneously, I've heard many experts say that that VAERS is also underreported. Do you agree with that?
It could be, but let's just take it on face value that it's every single one. One of the things that we learned is